Thank you very much for watching this presentation on point-of-care ultrasonography of the inferior vena cava. My name is Genevieve Desi and I'm a general internist at the University of Calgary. So bedside ultrasound of the IVC can be really helpful in making real-time decisions about patient care. It's often used to estimate right atrial pressure, can be used to estimate volume status, and also fluid responsiveness. So during this presentation, I'm going to go over the anatomy of the inferior vena cava, basic information about the technique that's used to image the IVC. I'll talk about how you can differentiate the IVC from the aorta on bedside ultrasound, and also how you can use the information gathered from imaging the IVC to predict right atrial pressure. The IVC runs parallel to and slightly to the right of the abdominal aorta. As these two vessels course through the diaphragm, the aorta dives deep or posterior to the IVC towards the thoracic aorta and eventually the aortic arch. The IVC enters the diaphragm more superficially or anterior, as seen on this short video. So now we'll move on to talk about how to perform bedside ultrasonography of the IVC. So to image the IVC, you can use either the phased array probe, which is sometimes referred to as the cardiac probe, or the curvilinear probe, which is sometimes referred to as the abdominal probe. Both of these are low-frequency probes, which can penetrate far enough to see the IVC deep in the abdomen. It's probably wise to set your depth deep to start out with, and then adjust as necessary once you find the IVC so that the vessel is in the middle of your screen. The top image on this slide shows where you should place your probe to visualize the IVC. With the probe marker facing the patient's head, you should place the probe longitudinally just to the right of the patient's midline. Fan the probe left and right until you visualize the IVC, and then follow the vessel into the right atrium. Once you see both of those structures, try to slightly adjust the orientation of your probe until the IVC is seen across the whole screen. In an ideal view, you'll be able to see the right atrium, the IVC, the liver, and the hepatic vein. The image at the bottom of the screen is lined up with the anatomy at the top and shows you some of the major structures that you'll see when imaging the IVC. So this is an example of what you'll see once you find the IVC. Here you can see the liver superficially, meaning it's at the top of the screen, and the IVC, which shows up as a black vessel towards the bottom of the screen. On the left-hand side of this image, you catch a quick glimpse of the right atrium and the hepatic vein at one point. So now I'll move on and mention how you can differentiate the IVC from the aorta, as without this knowledge, these structures can be confused. When it comes to location, as shown in the video earlier, the IVC is slightly to the right of the spine, whereas the aorta is slightly to the left. The IVC has a thin wall with minimal biphasic pulsations, whereas the aorta has a thicker wall and should pulsate with one pulse. When it comes to dynamic changes in the shape of the vessels, the IVC often decreases in size with inspiration, whereas the aorta should not vary with the respiratory cycle. One last method of telling these two structures apart is that proximally the IVC should be more superficial and directed towards the top of the screen, whereas the aorta will dive down a bit deeper or posteriorly to enter the diaphragm further back. The video on the left shows the course of the IVC, which is somewhat horizontal across the screen. The video on the right shows how the aorta dives deeper into the abdomen. Now, a main reason to perform bedside ultrasound of the IVC is to predict a patient's right atrial pressure. In order to do this, you have to make a few simple measurements. The first measurement to determine is the size of the IVC. Most people measure IVC diameter approximately 15 to 20 millimeters caudal of the hepatic vein IVC junction. This measurement should be done at end expiration, because in non-ventilated patients, this will be when the IVC is most full. Before measuring the vessel diameter, it's very important to fan the ultrasound back and forth until you're happy that you have found the maximal diameter. Because of the shape of the IVC, it's easy to measure the diameter to the side of midline, which could underestimate the true diameter. The second measurement to determine is the collapsibility index, a term used to describe the degree of collapse of the IVC with respiration. This is measured by taking the maximum diameter found, which should be at the end of expiration, and subtracting the minimal diameter, which is usually inspiratory. You then divide this result by the maximum size, and this will provide you with a percentage. This video shows an IVC that's large and does not vary much with respiration. This video, on the other hand, shows an IVC that completely collapses with inspiration. There are multiple ways to actually measure the collapsibility index. One method is to look at the image and just eyeball it, or guess the degree of collapse as a percentage of the largest diameter. The second is to pause the image and then use the calipers to measure the largest and then the smallest diameter, and then calculate the collapsibility index. And the third is to use M mode, which I will show you next. First, take a look at this image and try to guess in your head how collapsible you think this IVC is. In order to measure the collapsibility index of this patient's IVC using M mode, you have to start by pressing the M mode button on your machine. This will cause a vertical line to appear on the screen that you need to line up with the location that you would like to measure. As I mentioned, this should be approximately 15 to 20 millimeters from the entry point of the hepatic vein. You then have to press M mode again, and you will see a screen like this, where images along that line are then displayed over time. You'll see that a black area is created on the screen that represents the IVC. Once the image fills the screen, pause the image, and again use your calipers to measure the maximal and the minimal diameter of the IVC throughout the respiratory cycle. You can then plug these numbers into the equation to get a result of the collapsibility index. This table is probably the most important take-home message from this presentation, as it shows you the cutoff values for IVC diameter and collapsibility index that are used to predict right atrial pressure. If the diameter is less than 2.1 centimeters and the collapsibility index is greater than 50%, the right atrial pressure can be presumed to be high. If, on the other hand, the IVC diameter is greater than 2.1 centimeters and the collapsibility index is less than 50%, the right atrial pressure can be predicted to be high. If the IVC diameter and the collapsibility index are somewhere in between, it's assumed that the right atrial pressure is intermediate. And sorry, I think I said at the beginning that when it's less than 2.1 and greater than 50%, it's high, but that should actually be normal right atrial pressure. So again, take a look at this video and try to guess in your head how large the IVC is and how high the collapsibility index is. I would guess that the diameter is less than 2.1 centimeters, but the collapsibility index is less than 50%, meaning that the right atrial pressure would be expected to be intermediate or normal here. In this example, the IVC diameter is less than 2.1 centimeters and the collapsibility index is greater than 50%, meaning that the right atrial pressure would be expected to be low in this situation. So how good is bedside ultrasound at predicting high right atrial pressure? Brennan and colleagues gave 4 hours of didactic training to internal medicine residents on IVC ultrasonography and then asked them to complete 20 supervised scans looking for IVC size and collapsibility index. Residents were then asked to predict whether patients had high right atrial pressure by either performing a JVP examination or by looking at the IVC with a handheld ultrasound machine within 1 hour of a cardiac catheterization. They found that the residents were able to get adequate images 90% of the time using handheld ultrasound, but were only able to see the JVP adequately in 63% of the patients. The handheld ultrasound far outperformed the JVP exam in its sensitivity and had a similar specificity to the physical examination of the JVP when it could be seen. Like anything else, there are some limitations to predicting right atrial pressure with a bedside ultrasound machine. Collapsibility index cannot be used in mechanically ventilated patients, for whom a distensibility index needs to be used instead. The collapsibility index can be affected by many other variables, including respiration effort, blood volume, and the presence of cirrhosis. Lastly, if there is a lot of diaphragmatic movement with respiration, M mode may not be the best way to measure IVC diameter, as you will end up with measurements at two different locations in space. So thank you very much for taking the time to listen to this presentation. If you have any questions or concerns, please feel free to contact me.